Good morning. Good morning, friends and colleagues. Good morning, and visitors and expert panel and so on. Thank you very much. I'm going to start this morning. I'm Yvonne Doyle. I'm the chair of one of the groups on the London Health Commission, particularly looking at health and inequalities and disadvantage, which is one of the distinguishing features of this particular commission that we want to keep in sight. I'm also the regional director for London for Public Health England, which protects and promotes the health of Londoners at a London level. So it's a great privilege to be doing this particular part of the Commission and to be here today. And my first and important thing to say is to thank you for joining us. We really do appreciate your time and your expert perspective, and your perspective, whether you think it's expert or not. That's what we want to get from this morning. We have a panel here, and I'm going to introduce them now and then just give the batting order. I've got Dr. Sam Everington, who will be probably very familiar to everyone here, health champion par excellence for East London, and will never let us forget about the people of this area whom he loves dearly, and I hear about that very regularly. We're very fortunate to have Len Duval, who is going to give us that political perspective and also that leadership perspective at a London level, so I'm very grateful to Len for joining us. And we've got Professor David Fish from UCL Partners, who have been fantastic. I mean, they really have lived out the partnership role with us on the public health side, particularly on mental health, but on a range of other issues, where we get the expert evidence as to what works, and then really it's up to us to see how we do that, what we do about it. So those are our expert guests with us, but we really are here to listen to you. And we have, I think we probably should go round the table in a minute, but I just wanted to start that way. My role as chair is to keep us to time, to do a bit of boring housekeeping, like reminding you to turn your mobiles off, and if you are asking questions, to wait until you get a microphone. As you can see, we have got media here. We will record this for posterity. So it would be good that you're heard. We have 3 sessions this morning. They last approximately 40 minutes. So we have one now from 9:40 until 10:20. And its theme is improving the quality and integration of healthcare services. The second will be about the social determinants of health, particularly with a focus on homeless people and the disadvantaged, the dispossessed, which is very much what the Commission is also looking at. And the third will be around improving the quality, the third will be about the health of people in London, and we'll have a very strong contingent from East London talking to us about that as well and bringing that perspective. Before I go forward, I just wanted to give you the lines about Providence Row, the place we sit in. Now, forgive me if everyone knows this backwards, but I don't, and I think perhaps some other people don't, and it would be good that we knew that they look after over 1,000 homeless people in London, and particularly in East London, and they offer really what's close to public health's heart: learning opportunities, life opportunities really, and training. And to try and get people into the mainstream, into a safer and healthier life, off the streets. And it really can include very intense one-to-one support, particularly for enduring mental health and substance misuse issues and needle exchange. It's a charity, and its pilot hospital pathway project has supported 25 patients at risk of homelessness right now at the moment. For that, we are very grateful for them hosting us this morning. And we've just had a very interesting visit to Health E1, which is the nurse-led PCT medical services practice, a very, very impressive outfit, really looking at the absolute need of the people who come in who have nowhere else to go. And as one of the nurses said to me, it's heaven in here, and when I go out on the street it gets to be hell again. And those professionals are there every day for those people. So that was fantastic, and they are well connected into other parts of the system. So we've been educated a bit this morning. We're now going to open the session on the integrated health and care. Could I, rather than me try and do a cat-handed version, could I ask folk around the table just to say who they are, please, starting with
I'm
Catherine.
Catherine Pollard. I'm the Pricing Development Director and at Monitor, but I'm also the policy lead for integrated care there. And I'd also like to say that I started my NHS career working in Tower Hamlets, both for the PCT and then working on BARTs, working for BARTs when they took on the community services and doing some integrated care work. So I have great fond memories of working in East London.
Thank you, Catherine.
So I'm Andrew Dean. I'm a consultant cardiologist, but do lots of other things. So I work as clinical director of acute medicine at Barking, Havering, Redbridge. And remember that Barking and Dagenham has as much deprivation as Tower Hamlets, Hackney and Newham. And we also have a very elderly population in Havering, so we have our needs as well. I'm also involved with UCLP, involved in training of higher specialist trainees in general medicine, and have various other roles around, and I work at London Chest as well.
Thank you, Andrew.
So I'm Dr. Magda Smith. I'm a consultant physician and gastroenterologist and an associate medical director at Barking, Havering and Redbridge Trust. It's just a pure fluke you have us both here today. And lead on a lot of the work that we're doing around integration of services and the acute services in the trust.
Hi, good morning. I'm John Waddell. I'm the Deputy Chief Officer at Tower Hamlets Clinical Commissioning Group, and then act as in a leadership role around integrated care on behalf of Newham, Waltham Forest and Tower Hamlets.
Thank you, John.
So I'm Jane Milligan. I'm the Chief Officer for Tower Hamlets Clinical Commissioning Group, and have worked in Tower Hamlets for about 14 years, doing a number of roles. I'm a clinician by background, but I've been working in commissioning for certainly the last 10 years, I think.
Hello, Magda.
I'm Robert McCulloch-Graham. I'm Corporate Director for Tower Hamlets Council. My responsibilities are education, children's social care, adult social care and public health.
Thank you very much indeed. And we are expecting Beth and George. She may join us, but Beth and we will try and get that perspective, Deputy Director for the Integrated Care Programme in Tower Hamlets CCG. But as we say, we have Jane with us as well. So thank you very much indeed. Now, I think the way to do that we have a number of perspectives that if things are going slow, we can ask, but perhaps we could open this. This is about improving the quality of integrated care and care services. So I think probably the right way to do, there isn't a method for this, is that we ask our panel to give us that perspective, and then we open the floor for questions, and we probably should leave, I think, about 10 minutes or 15 minutes for questions and comments from the floor. So if we are now, sorry to be a bit mechanic about this, but we're now 9:45. If we just stopped about sort of 10:10 to give people a perspective from our guests on the floor, is that okay? So would anyone like to start just giving us, it would be very interesting to know any successful examples of integrated care. I mean, this is probably business as usual for many people, but it's become a big issue around the relationship between out-of-hospital local government and indeed the NHS. And we're really looking for examples of how this works, particularly with these people, these patients in perspective, really, the people we're meeting here today.
Well, can I kick off?
Magda, yeah.
So I've worked in outer North East London for about 18 years as a consultant. I think in that time, as Andrew's already explained, we have quite a wide and diverse population, which ranges from a very large elderly population in the outer side, the east side of London, and high levels of deprivation, particularly in Barking and Dagenham, and widely diverse cultural population, and a large immigrant population, which over the years has changed in the nature of the background of the immigration, and I think that's probably an experience in North East London as well. Yeah. The challenges that I think we face are that over time we have increasingly increased the number of doorways that people can access care through, and I am going to speak very much from an acute perspective, that's my background. We have created, in order to allow access, we've created multiple places where people can access. And my experience is that Londoners will go where they can get what they want. They don't follow prescribed pathways. And very often that means that people, particularly with chronic illnesses, for example, will pitch up where they feel they need to pitch up. And one of the huge issues we have is lack of information, background information about baseline for patients, and the ability to pick people up and turn them around. And very often, people who've got a minor teetering of their chronic illness, that means they just need a little bit of extra input, not in the acute sector, very often find it difficult to access that at the speed that they can perhaps access an A&E department. So what we see is, from my perspective, people who are coming to A&E who don't need to be coming to A&E, or when they get there need to be able to be assessed quickly and access the right level of services out of hospital rather than the default of admission. So some of the work that we've been doing at Barking and Havering has been with our collaborative care team, who are based in the emergency department. It has input from general practice, community nurses, community social care. The team has direct access into various community health and social care pathways within the emergency department to pick up those people who perhaps historically would have been admitted because we didn't know what else to do. And we know that once you're admitted to hospital, your needs usually go up, the complexities go up, and your ability to leave hospital rapidly reduces. So that's one of the initiatives that we've had, but we've discovered with that very often people who are coming to hospital do not bring their baseline information with them. So if you have COPD and you obstructive airways disease and you turn up with an exacerbation, it's very difficult to assess what your baseline level of function is. So we've been working again with our CCGs and the community services with an integrated care project which allows information to be held in a common not very tech savvy, but in a common IT system.
Yeah.
That means when they present at the front door, the teams can access information about individuals, what their baseline is, who their community contacts are, perhaps who their social worker is, who their community matron is, to allow us, particularly with elderly patients, to be able to say, actually, you're at your baseline, we just need to phone your community matron, get her to come in and see you. And we can let you go home. So it's a work in progress. It's been done with all of our CCGs. That's, again, a complex landscape when you're working with 3 or 4 different CCGs, but actually they have come together to allow us to focus on common pathways.
And that's the integrated bit, isn't it, that you're working with the... So would others around the table like to give a perspective, particularly if you're thinking of mental health, where we often come across some of the most challenging... Yeah, Jane.
Well, I suppose if I just pick up the Tower Hamlets perspective and I suppose just reflect back. I mean, we talk about integrated care. We've been talking about it for a number of years, and certainly we've had a joint strategy with the local authority. Again, sort of since 2004-05, for essentially bringing services together. And that does include mental health services as well. I suppose certainly. If you think about integrated care, there are a number of different levels of that, and we've been quite successful, I suppose, of bringing together GP practices into networks, so integrating in that respect. And as Magda, pointed out, having a common platform of information is really critical for that. Part of the sort of next steps, I suppose, has always been then to bring within the networks and, in fact, the localities, because we have 8 networks. Who then work together to form 4 localities, is then, say, the commissioning and provision of locality integrated care teams, which includes social work, general practice, community services and mental health services. And John will explain a bit more detail, but particularly to target those people who are the most vulnerable and require that level of coordinated care. So I suppose when we try and talk about integrated care, I think we now talk about coordinated care, because that seems to be, that essentially is what we're trying to deliver.
Yeah, that makes more sense, that word, doesn't it?
Exactly. And having very clear sort of common approaches to that, both across in primary, community, social care and secondary care, so that there is a sharing of information, access to that information by all parties, and making sure sort of patient is central to that. So the sort of the care plan is essentially the roadmap for that patient who everyone can access, with the view then that actually what we try aim to do using a targeted approach, using again the IT system to do that risk stratification and call and recall, so that you can have a very proactive input to people who have the highest need, rather than people then, as say, essentially turning up in A&E because there's nowhere else to go. And then part of that has been, I suppose, building, particularly from a mental health perspective, building on essentially what we've had at the Royal London for a number of years, which has been a psychiatric liaison service within A&E, actually building on that and strengthening that as part of what's called the RAID model, taking the learning, I think, from Birmingham to particularly, I suppose, make sure that we're not just focusing on people's physical needs, we're actually focusing on the whole person, because generally, people have comorbidities, and actually it covers mental and physical health.
Thank you, Jane. So would Robert or John like to give a perspective? John, yeah.
I don't mind sort of building on that in relation to the sort of work that we've been doing across the sort of WELG footprint, really. So in essence, our programme really is looking at how we can integrate physical health, mental health and social care at pace and at scale. Again, I think the real issue that we're trying to address is how we can frame the case for change around the patient, which I think is being emphasised really, and ensuring that we look at the patient and being at home as being the centre of where we then look at how we can coordinate care around that, and has their complexity or their needs increased, we move slightly fan out from that process. I think it's important to reflect on some of the work we've done around sort of being able to use technology, particularly around stratifying patients so we know who we're talking about and how we might need to take a slightly more targeted approach around different cohorts in terms of that process. I think technology is equally going to be important around information, around sharing information, ensuring that whether that's health or social care, individuals have access to people's information and that they can respond to that. I think then the other area is how do we create an integrated system that really ensures that we've got an intelligent user and carer, but then equally how do we make sure that we've got intelligent commissioners and intelligent providers who can deliver the care around that.
So, sorry, Robert, would you like to give us just a perspective before I ask a question that's prompted? Thank you.
It was just a couple of points really in what people have been saying before. I find it really despondent really that 2014 we're still talking about information sharing. It just beggars belief really that we're still at this stage where we're not sharing information and data. I've had 2 years of working with the National Programme for Troubled Families, and we came across this issue around data information and data sharing, and the problems were with professionals. They weren't with the troubled families themselves. About 99.9% didn't care where their information went at all. So I think we're tripping over ourselves and trying to be so correct around information sharing that I think a lot of the patients actually want us as professionals to be sharing it and getting the information. So I hope in 10 years' time, after I've retired, that we're not still facing this issue of information sharing. The other part I just wanted to pick up was I'm quite new to health. I've been in local authorities for about 30 odd years, and having public health coming into local authorities is a huge opportunity for us. And now that I have adult social care as part of the overall directorate, we're very keen to make sure that join-up takes place. And one of the barriers, I think, the historical barriers, are budget holders and people who are responsible for particular parts of the budget. And until we can actually overcome the governance issues around who's accountable for which particular budget, I think we're forever going to be cost shunting, we're forever going to be separated, and the join-up that we're talking about and the integration is going to be hampered until we actually do that. I think the CCGs is a great way forward for actually doing that, and I really, really welcome it. I know that across the country there are different standards, there are different positions within that. I'm fairly new to Tower Hamlets, and what I've seen here I'm quite impressed with. So I think there is a huge opportunity now through the CCGs to actually get that actually motoring. And the involvement of GPs and GP practices within that on a locality basis will help us actually join our services up on the ground, which I think will be the most effective thing that we can actually do.
Yeah. Thank you very much. I'm conscious that Andrew and Catherine haven't yet commented, so you may wish to.
In our acute setting, one of our big problems is discharging patients, and each ward of acute medical patients will have a group, sometimes half of the population of that ward or more, who we're trying to get out of hospital, and there are barriers working with services outside of hospital, both medical and local authority services. And I think you're right, if we shared a budget or we took away the walls that separate the budgets and work much more closely together, we'd be far more effective. So having patients in hospital for longer than is necessary, one, is not good for the patients. That's the first thing. They tend to get ill whilst they're waiting. And secondly, it's terrible for the acute service because we're blocking beds and then patients are stuck in A&E waiting to come into the service. And I think that's true for ourselves and for most of our partners in throughout the country, and particularly in North East London. So trying to work together, we have NELFT, the North East London Trust, who we need to work with, and we need effectively to work as a single group, and getting to that point is really important, and I suppose CCGs have an important role to play.
So that's a very interesting ambition, and good luck actually. Catherine.
So from a national perspective, what we're really trying to do, particularly at Monitor, but also is working alongside other national partners like NHS England and the Local Government Association and the department, is really work out what support we give local areas for making this happen. How can we unlock some of this innovation and start removing some of the barriers, whether they're real or perceived, to basically enable the system to work together, as you've just described, to meet the local population needs. So some of the things that we're doing is thinking about what's necessary to make the commissioning system support this. Obviously, NHS England are doing quite a lot of work on joint commissioning. There's been a lot of that in the press in the last few, or at least in the health press in the last few days, which is something that I can't really comment on. But what we're really trying to do, and actually we've been doing some work working with a number of local areas in London, so the North West London integrated care teams, as well as the WELC ones, is to help them to understand what their population is. So we've done some analysis of linked data sets. I mean, it reveals really, really good and helpful insights in how different patterns of consumption then lead to different costs, and particularly what differentiates different populations. So the differentiation between someone with serious and enduring mental illness, someone from dementia, or someone with multiple long-term conditions, and to support them to create new contracting vehicles effectively that will enable them to describe what matters to the users. Camden are doing some really great work around working with their population to come up with their outcomes that they want to put on in their contracts, and then really work out how we can do some of the technical thinking around making the money work. So how do risk shares work? How can you have providers come together to have shared financial governance, so that you can create more single areas of financial and clinical accountability. But it's really one of being enabling, because it's for local areas to describe what they want to commission in response to their local needs.
So can I just clarify a point? Did I miss this? Are you actually working as Monitor with commissioners?
Yes.
Yes, okay, that's an interesting thing we may wish to explore. Can I ask our panel here, would they wish to reflect on any of this? Sam? Yeah.
It's a question for Magda. I'm very aware in primary care, certainly in Tower Hamlets, the journey's started. So you've got coordinated care now for at least 2% of the population, mainly the housebound, terminally ill, which is absolutely vital. 60% are still dying in hospitals with terminal illness. That is a tragedy for everybody. And so that's going to shift up to about 20% of the patients in primary care. And potentially shift 10% of the work out of hospitals, potentially. We don't know exactly. These are estimates at the moment. Critical to that is what I think is somebody like you, who is both rare and special, because you're not a specialist. And so my question to you is, how do we make more of you? How do we magnify the rest of the consultants in the hospital and take them on this journey of recognising actually they're part of a pathway for patients, but they need to take responsibility, like all of us, for the whole of the pathway.
So I think it's a national debate, isn't it, at the moment, about the specialist, the generalist, the person who's able to see the whole patient rather than focus on the single organ. I do some specialist work as well, but actually I love the more general side of it. I think that we have got to look at how we are educating and training our docs that are coming through. I think that we need to look at who it is that really heads up this sort of general team. And I have to confess, in the project that we've been doing, it's our geriatricians actually that have been at the forefront of it, and they are probably our biggest generalists within the organisation. I've learned a huge amount from them. They're passionate about keeping people in the right care setting and not assuming that hospitals are the right place to be. So I think we need to get the learning from them into our more specialist thinking, to try and improve the education of our existing clinicians, but also our trainees, into not going down just the super specialised route of training. We need the specialists. We need Andrew in the middle of the night when we've had our myocardial infarct, because he's the only one that can do the angioplasty. I wouldn't be any good to you. But when it comes to trying to integrate services, we need to be integrating not just the clinicians who are working in the acute sector, but actually working much more closely with our GPs. One of the things that we're in the process of doing is, and I suspect Hamlets is actually ahead of us here, but just the assumption that the GP sits here and the acute sector sits here. Actually, the patient is the focus, and actually having good MDT working. So for the small population of who are in the integrated care system, actually having regular MDTs about what's going on with patients, with various people who are working.
MDT
I'm terribly sorry, yes. So MDT...
Because they're really important, so I think it's really important.
They are absolutely critical to working. So an MDT is a multidisciplinary team, so that may be a secondary care specialist, a general practitioner, might be a therapist, might be a social worker, might be a community matron, anybody who is involved in the holistic care of the patient. And MDTs very often will involve patients and families as well, about discussing, planning care around that individual, making a plan of care that everybody understands that we need to follow through.
Look, I can give you an example. So you can be a specialist and do this as well. So I, as well as doing angioplasty 1 day a week, I am the consultant involved in our coronary heart disease project in Barking and Dagenham, which is now spread throughout the Nelft area, CCGs, 3 Northeast London, outer Northeast London CCGs. So we've been running for about 5 years now a service where patients are referred as much to their GP specialists and specialist nurses to be seen in the community. So in Barking and Dagenham, they're seen in Porters Avenue Health Centre, which is a nice new health centre that also runs GP services and nursing services. They're seen initially by some specialist nurses who do initial assessments. Then they may be seen, if necessary, by GPs with a special interest in cardiology. And then every other week I come along and we spend Friday lunchtime going through the caseload where they've picked out the patients and need further discussion. And they can bring in palliative care teams for patients who've got severe heart failure and end of care. They can speak to the GPs to get additional input into other areas of their healthcare, or they have contacts with the local authorities to help with housing needs and so forth, and that works really well. So that's an integrated service for a particular specialty, and they'll also liaise with people like the COPD service if necessary, and that works really, really well. We've learned lots from that. What I think the most important thing to learn is that you don't want to replicate hospital services in the community just for the sake of it, supposedly to save money. What you want to do the stuff in the community that really makes a difference to the patients, and make sure that the complex stuff is still done in hospital, but the patients are discharged to the community service at an early stage rather than just keep them coming back and wasting their time coming to clinics unnecessarily. And it's a really effective model and is spreading out.
Thank you very much, Andy. David, did you want to reflect here?
Yeah, I'd like to say a few words. I think the power to make change probably sits in the other half of the room rather than this half of the room.
We're coming on to that, David. Nearly 10 past 10.
Quite a deep issue for me, looking at the evidence and hearing the comments which resonate so much around the table, because it seems that people are always talking about trying to solve component problems. So we've heard about professional barriers, institutional barriers, the governance barriers, the regulators. You have to pardon me, Catherine, have regulate institutions, but patients are not institutions. You regulate the institutions. Everyone who works in the institution looks to the regulator, not how do we organise care around the patients. So you hear all these component problems that need solving, like informatics or the way training is done, but it really comes down to values and relationships. None of these are very difficult things to solve if you decide that you would have an organising principle around the patient journey rather than an organising principle around institutions. And I suspect the institutions will never give up that organising control, lest people in the other half of the room do. So I'm expecting to hear a lot of loud voices.
Well, that's a very good prompt for us to actually do just that. So we've got about 10 minutes, and I'm sure there are people sitting here who would want to comment or just reflect on what they've heard. So please feel free to do so. Is there anybody who'd like to start that? And just when you do, please say who you are. And if we can keep it fairly concise, we've just got 10 minutes. Thank you. Victoria.
Victoria Barrett, the Deputy Mayor of London.
And we'll give you the mic as well, Victoria. Thank you. Yeah.
Sorry, Victoria Barrett, the Deputy Mayor of London, representing Boris. I've been listening in on many of these sessions, which have been absolutely fascinating to hear the expertise. I just want to go back to something that we heard yesterday, which takes back to Robert's point about sharing records. And it was made, the point by one of the speakers yesterday on the panel was, why don't the patients have their own records? After all, they are their records. I understand that technically they're held by the Secretary of State, but actually if therefore they had it either, nowadays, and if you move on, and after all the work you're all doing is not about health changes that are going to happen today and tomorrow, they're going to happen over the next 5-10 years, and more technology is going to be used. And I just, back to the integration that you've all talked about and how you're trying to smooth the patient journey, just could we go back to the view of, if the patient had the records, then they would actually know what their normal, if they were either on their Fitbit around their, or kept in some other way, or even on some other file. So just, I don't think the point that was made by Robert was actually sort of talked about much. I didn't know if the panel could talk a bit more about that. Thank you.
Thanks, Victoria. What we'll do is we'll take maybe a little bundle and then we'll come back to the panel. So other reflections? Yes, there is somebody there. I think that's Showman, is it? Yeah.
Thanks. I'm Showman Banji. I'm Director of Public Health, Tower Hamlets. Robert will be bored of me telling this story, but since Public Health moved to the council, one thing that happened to me was that a social worker came up and said, right now Public Health are in the council, does that mean I have to tell my clients to stop smoking? And that's kind of so the point I'm trying to make is if you look at the health and social care integration, it is actually about hearts and minds of frontline providers, and for them to change their outlook and the way that they look at things and addressing professional boundaries. So kind of in terms of a message for the London Health Commission, I would say that one thing that could be really usefully be done is to really focus on the training of the workforce, both for local authority frontline providers and also for the NHS, and to take on a new vision which is about taking a much broader view of the patient, which actually looks at what about the housing conditions, what about income, and vice versa. So some of the social workers will look at the health issues around the patient, and there's a sort of dialogue at a local level, and at a very local level, people know who the people are. So the GP knows who the housing officer is, or who the benefits officer is. So there's that really local knowledge and integration of people at a local level of the providers. So.
Thank you, Sean. I wouldn't have expected anything less from the Director of Public Health. We probably have room for one or two more, and then we'll come back to the panel, because we can keep going on this. Alex is at the top, I think.
Alex Bax, Chief Executive of Pathway. I guess we will talk about this later, but it sounded to me like you're all saying everything's fine, we've got it sorted, it's going to be great. My feeling, talking to colleagues across the NHS in London and in health service and in housing and in homelessness, is that it's not good at all at the moment, and most people are very worried about things getting worse. So just the colleagues around the table didn't really give me that perspective. It sounded like we were going to move from a pretty good place to an even better place, and that's not what I feel. We might come on to this later sessions.
Okay, that's one of the loud voices. And then we had one more person, is that right? Yes, thank you.
Thank you. Carrie Battersby from Elft. Just a couple of points. Obviously, mental health services have worked in an integrated fashion for a long time. And I just want to echo the point that was made about budgets and the integration of budgets. I do think that's a major issue, not least given all the stretch on budgets at the moment. The other point I'd like to support is about services for older people. I think there's excellent examples of integration, particularly in dementia care, across voluntary sector, statutory and local authority services together.
Thank you, Kurt. So we've got four points here: patient health records, professional boundaries and training, and how that can work better locally, in fact, but the training needs to be right. It's not all right at the moment around housing and homelessness, and in fact London and everywhere is facing some serious challenges, as we know, in 2015. And just to keep older people in sight and remember that mental health has worked this way. Reflections on any of that?
So,
yeah,
as regards health records, there are obviously good examples of people carrying their own records. So if you're pregnant, you carry your own records, and that's been accepted for years and works extremely well, and it's very unusual for people to lose their records. So, and in our heart failure service, we've given patient records. The difficulty with electronic records has been the difficulty in setting up a NHS-wide computer system that works and doesn't cost billions of pounds. So one would have thought that it would be possible, but whenever people bring in new complex computer systems, it causes chaos initially. So it's a difficult one, and it's extremely expensive. How bad are things? Yeah, we'd be kidding if we said that things were all hunky-dory. We struggle. In our trust, we have huge financial problems. And our biggest issue is dealing with capacity, with a limited capacity, with the number of patients who are arriving at our front door and the number of patients who we're struggling to discharge. So there are really big issues, and probably the biggest solution, the most effective solution, will be effective integrated care. So we reduce the number of patients who end up at the front door of the hospital, and we optimise the discharge process by working in an integrated way. And there's a long way to go in that, so I completely accept it. We just like to give positive examples.
I know Sam wants to make a comment on this as well.
Just picking up on Showman's point, I think we need to recognise that we're probably only responsible in the NHS for 15 to 20% of healthcare, and therefore the wider determinants and this integrated pathway, not just this between hospitals and primary care, but actually the width of integration is absolutely critical. But I also, it might be John or Jane want to comment on this too, but there are two good examples of this in Tower Hamlets. One is access, the pilot access of EMIS for any patient, which you might want to comment on, and then something like social prescribing, connecting to all the 1,100, potentially to all the voluntary sector organisations in Tower Hamlets.
Jane or John, did you want to comment on either of those?
Well, you were bits to say as well. You pick on that bit.
Okay, so I suppose just picking up, as I say, the whole issue about sharing information, and the challenge that we've had in terms of a national sort of information system. I think we're now moving forward successfully in terms of knitting together patients' records on. We've got a single system for general practice. We're connecting into the hospital. And I think we're not far off from connecting into the social care system as well, and utilising sort of technology to do that. So one of the things that we are about to launch is the district nurses having iPads which will be able to access that information. And for me, the next step will be actually that technology being placed with the patient, so they actually have that ability to do that. And as Sam says, we have EMIS or GP access already. So that is moving certainly forward. And as Sam says, I think particularly in Tower Hamlets, and as I said previously, we recognise that just, we can't address all of the health needs or health issues without addressing the fundamental aspects of employment and welfare, and the link in with particularly in Tower Hamlets, the very rich tapestry of voluntary and third sector organisations is really critical, and being able to really ensure people access that. I think the key thing about that, though, is actually really looking at it as a population-based approach to care. So even though Tower Hamlets is a very small borough, there's quite a significant difference between the east and the west. And actually, I think by actually people taking responsibility for their population, that also helps address some of the professional barriers that we potentially have. And I think then the next step for that is also then bringing that into how people are commissioned or also are trained to deliver care. So instead of having district nurses, specialist nurses, primary care nurses, for example, we need to have a nursing approach to those people with those needs, and that's children, families, carers, and older people as well. And I think that's something that we are moving forward on, but certainly I suppose the power of doing that at a wider scale is obviously important too.
Thank you, Jane. And last comment from John.
Yeah, well, I'll just pick up some of those things. Absolutely, the aspiration around patients owning their own records should absolutely be critical. And again, building up on Jane's point about making sure that we really optimise and use technology as much as we possibly can going forward. Picking up on Showman's points, again, we've got to find ways of making sure that those wider determinants of health are built into the programme. And again, a particular area that I think we need to be focusing on is around sort of social isolation and making sure that that's built into that. I think the issue around training, my view is that we need to take an integrated approach around training, and we need to be thinking about how that integrates with education and OD, and that we need to be thinking about how we do that collectively across the system. So moving away from individual professional groups, having individual training, and much more about an integrated approach around how we can deliver that, and making sure that we build into that some of those values and some of those principles, and challenge some of those barriers around whether they're real or not, around how we might be able to do things very differently. Certainly don't think it's all sorted by any stretch of the imagination. I think we can give you lots of examples of where we think we've made improvements, but I still think there's huge challenges in terms of moving forward. And then my final point around budgets, I think budgets can be a real lever, equally so can contracting and various other things, but what's really important is that we have the right values, we have the right relationships, and we have people who are brave to do innovative things and break some of those myths and barriers to do it and work in a very different way.
Very quickly.
Yes.
So, okay, if we have the right values and the right approach, is the way to tackle and accelerate this agenda? Because I get the view, not just from talking to you, but to others, that we've got some great good practice and there's been some great improvements, but we need to move faster to accelerate those issues. So, is it prescription, or do we allow people to develop at their own pace? What should be prescription? What should be centrally dealt with? What should be left to you at borough? What should be left at sub-regional? Because it's just not good enough in London to have one borough motoring ahead and another borough not motoring ahead for whatever good, those reasons. So what would be those accelerators? Where would we take that from? Sorry,
fantastic question, and I'm sure that we could have a whole session on that, but it's one to leave with us because we might take it on. We have two further groups coming forward. I'm aware we're just a tiny bit over time. Robert, do you want to make a final comment on this?
I'll give you a very, very quick example.
Yes, thank you.
Something happened in Tower Hamlets. We got a call from a woman whose mother had been third time into hospital with a fall and was having an operation on her hip. She phoned us, told us that the flat underneath her was actually free. It had been set up for disabled use in the past. Her mother lived the other side of the borough. If we moved her into that flat, she would be able to be the carer because she lived above it. Could we do it? Now that cuts across every policy that I have, every access to resources that I have, and it cuts across about 3 or 4 different agencies. She was a very intelligent resident who actually knew the system and came straight to myself and, funnily enough, local politicians, which always helps. we were able to arrange all of those 4 agencies to line up to allow that to happen. And actually, it's a good result for the mother. It's a good result for her daughter. It's a great result for me because I saved massive amount in residential care, and it's gone down. And that will probably last for about 10 years because we're able to do that. But it is actually against all of the policies that I've got in place to do it. Now that's a patient-led, if you like, or a family-led individual who knows the system and turn it around. Just one answer to the question about is it going to get better. I've got to take 24% out of my budgets. We need to do things radically different. It's a time for generalists now. People have a responsibility across a range of issues. No longer can we deal with a specific illness. You need to deal with the whole person, and you need to deal with the family behind that. And for us, that's the integrated care.
Fantastic, and it's a great way to take forward those thoughts, to catch them and to move into the next session. I want to thank our panel. I'm very sorry, it's quite, there's so much more I know you'd like to have said, but we have 3 this morning to get the widest perspective, so I'm sure you'll understand. But please, can I thank you all for your contributions to that. We'll now take a few minutes break. We're supposed to start again at 25 past. I think we'll give ourselves a few more minutes. If we start at it was 25 past now, if we start at 10:30, would that be okay? Take a little bit of air, and we look forward to the next session. Thank you.